Welcome to the Deep Dive, your shortcut for getting a handle on complex health topics.
Hey there.
Today, we're really diving in, tackling a pretty big unit. We're aiming to synthesize 3 key pharmacology chapters.
Yeah, these ones focus on what you could call the body's outer envelopes. So think skin, eyes, and ears.
Exactly. Dermatologic, ophthalmic, and evatic pharmacology.
And what's really interesting about these areas is how much they rely on local topical drug delivery.
Right, so how you actually apply the drug, the formulation itself, that stuff becomes super critical.
Totally. It's often just as important as the active drug ingredient. So our goal today, for you listening, is to take all that dense info from your texts, like Lily's Pharmacology.
Which is a fantastic resource.
Absolutely. And turn it from just, lists of drugs into something connected and usable.
We'll be hitting the major drug classes, looking at how they work those mechanisms of action.
And crucially, we'll keep coming back to the nursing process, how that framework, assessment, planning, implementation, evaluation, how it guides you safely through all 3 of these, well, pretty different systems.
Yeah, showing that consistency.
And there's some pretty serious stuff tucked away in here, too.
Oh, yeah. Like what?
Well, we're going to talk about a common anti-acne drug, an oral one, that's so risky during pregnancy
I think I know the one.
that there's actually a federal registry, a whole program called IPLAG,
Okay.
just to manage the prescribing process.
Wow. Okay, that highlights the stakes.
Definitely. And then there's a glaucoma medication, really effective stuff
Mm-hmm.
that can actually permanently change the color of someone's eyes.
Permanently.
Yep. So these aren't just abstract facts, right? This is stuff you need to know for patient counseling, for risk management, like right away.
Okay, sounds like a lot to cover. Let's get into it. All right, let's start with the big one, literally. The skin. Our largest organ.
It really is. And before we even talk drugs, we got to respect the barrier we're dealing with.
The skin's functions, protection, temperature control, even vitamin D synthesis.
Exactly. And that protective function starts right at the surface. It has this slightly acidic pH, usually around 4.5 to 5.5. That's the acid mantle, the first line of defense against bacteria.
So structurally, what are we trying to get through?
Well, you've got 2 main layers. First is the epidermis, the outer bit. Super important point. It's avascular.
No direct blood supply.
Right. And the key part of the epidermis, especially for drug delivery, is the stratum corneum.
That tough outermost layer, dead cells, keratin.
Yep. Highly protective, water repellent. It's the main barrier.
So that's the gatekeeper. Drugs have to cross that.
Pretty much. To get a local effect, the drug needs to penetrate the stratum corneum and reach the layer beneath it, the dermis.
And the dermis is vascular, right? That's where the blood vessels, nerves, glands, hair follicles are.
Exactly. So absorption depends a lot on how thick that stratum corneum is and how hydrated it is.
So if the skin is broken or like really waterlogged.
Systemic absorption can just shoot way up, much higher risk.
Okay, this is where it gets interesting with topical drugs, the formulation. The base, the vehicle. We see ointments, creams, gels, pastes. You mentioned table 56.3 describes these. Why is the base so important?
Because the vehicle determines things like how occlusive it is, how much it seals off the skin. And that directly impacts hydration and therefore how well the drug penetrates.
Okay, give us a scenario. When would you absolutely want, say, an ointment?
Right, imagine someone has a really dry, maybe chronic patch of eczema, but it's a small area.
Okay.
Ointments are oil-based. They're greasy, yeah, but they're super occlusive. They trap moisture, hydrate that dry stratum corneum like crazy.
Which helps the drug get in better.
Precisely. Perfect for that kind of dry, localized lesion. Locks in moisture, maximizes penetration.
But if that same patch was like all over their back or on their face, maybe not so practical.
Exactly. An ointment might be too heavy, too greasy, cosmetically unacceptable, so then you might reach for a cream.
Creams are water-based.
Yep, lighter, less occlusive. They spread easier, feel better on larger areas, or places that are already moist, like skin folds.
Makes sense. And gels.
Gels are interesting. They often contain alcohol or propylene glycol. They tend to enhance the penetration of the active ingredient itself, kind of help drive it through that keratin layer.
So good for getting the drug deeper.
Potentially, yeah. And then pastes, think zinc oxide, diaper rash cream.
Thick stuff.
Very thick. More powder than ointment, really. They're not designed for penetration so much as being excellent physical barriers. Great protectants. Hashtag tag 1.2 dermatologic antimicrobials and burn treatment.
Okay, let's shift to infections. Common bacterial ones like folliculitis or impetigo.
Right, in pedigo, you often see those sort of honey-colored crusts.
Hmm.
Very characteristic.
And these are typically caused by Staph aureus or Strep pyogenes,
Yeah, those are the main culprits usually. So we need topical antibacterials.
like bacitracin. That one's been around forever.
It has. Works by messing with bacterial cell wall building.
Then there's mupirocin. That one's used a lot for impetigo too, right? And something about MRSA.
Yes, very important use for mupirocin is trying to decolonize the nose if someone's carrying MRSA, methicillin-resistant Staph aureus.
Okay, but you hear a lot about resistance with mupirocin now. Is it still effective?
That's the tricky part. It can be,
Yeah.
but resistance is definitely increasing because it's been, well, maybe overused sometimes.
So as a nurse, you gotta watch closely.
Absolutely. Assess the site. Is the impetigo getting better? If not, or if it keeps coming back fast, the drug might not be working anymore due to resistance. Need to flag that, maybe switch to something systemic.
Okay. Now, a really high-stakes situation, burns. Silver sulfadiazine, brand name Silvadene, is key here. Why topical? Why not just give IV antibiotics for a bad burn?
It's about the blood supply, or lack thereof, really.
Uh,
A severe burn just destroys the local vasculature. The blood flow to that burned tissue is drastically reduced.
so even if you pump antibiotics into the bloodstream,
They just can't get to the site of infection in high enough concentrations to do the job effectively. The delivery system is compromised.
so topical is the only way to get the drug right where it's needed.
Exactly. Silver sulfadiazine works directly on the burn surface to prevent or treat infection in second and third degree burns. But there's a huge safety point here.
Let me guess. Allergies.
You got it. Silver sulfadiazine is a sulfa drug derivative. So it is absolutely 100% contraindicated if your patient has a known sulfa allergy.
Critical assessment point. Gotta ask that allergy question every time.
Every single time. In the classic allergy crossover,
Yeah.
#tag 1.3, the complexity of antiacne and antipsoriatic agents.
All right, let's tackle acne vulgaris. Super common, right? Complex causes genetics, stress, hormones.
And bacteria, specifically Propionibacterium acnes or P. acnes. It likes anaerobic conditions.
So first-line treatments often include benzoyl peroxide. How does that work?
It's kind of cool, actually. It has a dual action. First, it slowly releases active oxygen.
Oxygen. Lethal to anaerobic bacteria like P. acnes.
Exactly. Kills them off.
Mm-hmm.
Second, it's a keratolytic.
Meaning?
It softens the outer skin layer and makes it peel.
Yeah.
Helps open up clogged pores, the comedones.
Okay, but patients need patience with this one, right?
Oh, yeah. You have to tell them, expect some irritation at first,
Uh-huh.
maybe redness and peeling. And it takes time, usually 4 to 6 weeks of consistent use to really see improvement.
Good counsel. Now the retinoids. Topical tretinoin retin-A is a common brand. Powerful stuff.
Very powerful. Tretinoin basically speeds up skin cell turnover like crazy.
Forces the skin to shed faster.
Yep. Reduces the stuff acne bacteria feed on.
Yeah.
But it also has these significant anti-aging effects, too.
How so?
It actually stimulates fibroblasts and collagen formation in the dermis. Helps repair sun damage.
Wow. So rebuilding from below. But that sounds like it makes the skin pretty vulnerable.
It does. Immensely vulnerable. Because you're constantly shedding that protective stratum corneum, the new skin underneath is very sensitive.
Sunscreen is non-negotiable then.
Absolute critical. High SPF, broad spectrum every single day. And another big warning. No waxing.
Waxing, why not?
The skin is just too fragile. Waxing-treated areas can literally rip the skin off. Severe irritation, potential scarring. Got to warn patients about that.
Okay. Now for the one you mentioned earlier, the really heavy hitter, oral isotretinoin. For severe cystic acne that doesn't respond to other things.
Right. This one works systemically. It dramatically inhibits sebaceous gland activity, basically cutting off the oil supply that P. acnes needs.
Super effective, but carries that huge risk.
Pregnancy category X, proven human teratogen, causes severe multiple birth defects, no question about it. Because it's oral, it gets absorbed systemically.
And that led to the IPL-EGI program. You have to be enrolled.
Mandatory. For prescribers, pharmacies, and patients, especially female patients of childbearing potential.
What does IPLD require? It sounds intense.
It is. 2 reliable forms of contraception are required, starting 1 month before therapy, continuing throughout, and for 1 month after stopping.
2 forms, wow.
Yep. And monthly pregnancy tests are mandatory before they can even get the next prescription filled.
Any slip up, and the drug stops.
Immediately. Plus, there are links, reported associations between isotretinoin and depression or suicide risk. So, regular mental health screening is also part of the monitoring. It's serious business.
Definitely. Okay, switching gears a bit. Psoriasis, this isn't an infection, it's an immune system thing, right?
Yeah, chronic inflammation, rapid skin cell turnover, it's complex polygenic inheritance.
So treatments target that rapid cell growth. You mentioned another retinoid, tazarotene.
Right, tazarotene, also used for psoriasis, specifically plaque psoriasis. And guess what?
Let me guess. Pregnancy, category X.
Bingo. Same strict pregnancy precautions as isotretinoin. Then there's calcipotriene.
That sounds like vitamin D.
It's a synthetic vitamin D3 analog. It works by binding to receptors on the keratinocytes, the main cells in psoriasis plaques.
And what does that do?
It helps regulate their growth and differentiation, kind of normalizes that out-of-control cycle, reduces the scaling and thickness.
Interesting. And what about older treatments, like tar?
Coal tar products are still around. They have antiseptic, antibacterial, and antisporaic properties.
Yeah.
They basically help soften and loosen those thick, scaly psoriatic patches. Messy, but can be effective for some people. Hashtag tag 1.4 miscellaneous agents and parasiticides.
Okay, couple of other interesting skin agents. Minoxidil Rogaine started as a blood pressure drug.
Yeah, systemic vasodilator. They noticed a side effect was hair growth.
Huh, so they made it topical for hair loss. How does it work?
The exact mechanism isn't perfectly clear, but we think it prolongs the anagen phase, the active growth phase of the hair follicle.
Okay, but because it started as a vasodilator, risk of systemic absorption.
Definitely a concern. If you apply it to a large area or if the scalp is irritated and more permeable.
Like after intense scratching.
Right. You could absorb enough to get systemic effects, tachycardia, flushing, maybe fluid retention, something to watch for.
And you mentioned something about blow dryers.
Yeah, interesting patient teaching point. Using high heat, like from a blow dryer, right after applying it, might actually reduce its effectiveness.
How come?
Could increase evaporation off the scalp rather than letting it absorb into the scalp. Heat generally increases absorption through skin, but here it might just make the volatile components disappear faster.
Good tip. Okay, another one. Fluorosil. That sounds like a chemo drug.
It is. It's an anti-neoplastic agent, an antimetabolite. We use it topically for precancerous lesions, like actinic keratosis.
Those rough, scaly patches from sun damage.
Exactly. And also for some superficial basal cell carcinomas.
How does chemo work on the skin?
It targets rapidly dividing cells. So it messes with DNA synthesis and destroys those abnormal, fast-growing cells in the lesion.
Sounds like it would cause some irritation.
Oh, absolutely.
Yeah.
Patients need to be prepared. The treated area will get inflamed. Redness, blistering, erosion, crusting that's expected.
That sounds awful.
It looks rough, yeah. But it's actually a sign the drug is working, destroying the bad cells. Crucial education point so they don't freak out and stop the treatment too soon.
Gotcha. Okay, last category here. Ectoparasiticides. Drugs for lice and scabies. Permethrin is common.
Right, permethrin is a neurotoxin for the lice and mites. Kills them off.
But treating the person isn't enough, is it?
Not at all. The critical part is environmental decontamination and treating close contacts simultaneously. Otherwise, reinfestation is almost guaranteed.
So, washing bedding, clothing in hot water, drying on high heat.
All that. Bagging items that can't be washed. Vacuuming. And everyone in the household, or close contacts, needs assessment and maybe treatment.
What about the knit combing? That sounds like a nightmare.
It can be. Traditionally, you had to meticulously comb out all the eggs, the nits, but some newer prescription drugs like spinosad or topical ivermectin,
Yeah.
they're often ovicidal, meaning they kill the eggs too. That can sometimes eliminate the need for that super tedious knit combing. Huge plus for compliance, especially with kids.
Definitely a win. Okay, that wraps up the skin. Let's move inward to the eye. All right, shifting focus now to the eye. Such a delicate, complex structure.
Absolutely. Key parts to keep in mind. The cornea, that clear window at the front.
Non-vascular, right. Needs to be transparent.
Exactly. Then the iris, the colored part that controls the pupil size. The lens behind it does the focusing.
And that's where cataracts form when it gets cloudy.
Right. And then the retina at the back with the rods and cones for vision. But for glaucoma, we need to understand the eye's plumbing.
The fluid dynamics.
Yeah. There's a structure called the ciliary body. It's constantly producing this clear fluid, the aqueous humor.
Okay. Where does it go?
It fills the front part of the eye, the anterior chamber, provides nutrients, and then it's supposed to drain out. Primarily through a network called the trabecular meshwork, eventually exiting via the canal of Schlemm. Think of it like a drain.
So glaucoma happens when that drain gets blocked or can't keep up.
Essentially, yes. It's a group of disorders where the intraocular pressure, IOP gets too high because the aqueous humor isn't draining out as fast as it's being made.
And that high pressure is what damages the optic nerve.
Precisely, leading to irreversible vision loss if untreated.
Are there different kinds of glaucoma? I think the book mentioned a table 57.1.
Yeah, two main types. First is angle closure glaucoma. This is often acute, an emergency.
What happens?
The angle between the iris and the cornea physically narrows or slams shut, blocking the drainage pathway suddenly. IOP skyrockets.
Symptoms would be severe then.
Oh yeah. Intense eye pain, headache, blurred vision, nausea. Needs immediate medical attention to lower the pressure.
Okay, that's like EQ1. What's the other type?
The much more common type is open-angle glaucoma. Here, the drainage angle itself looks open, but there are microscopic changes in the trabecular meshwork, that drainage tissue.
Making it less efficient, like a slowly clogging drain.
Exactly. The outflow is reduced gradually, so the pressure builds up slowly, often painlessly, over years.
That sounds insidious. People might not know they have it.
That's the danger. Significant vision loss can occur before symptoms are noticed. Makes routine eye exams, especially IOP checks, so important. Hashtag 2.2 anti-glaucoma drug mechanisms. The balancing act.
So if the problem is too much fluid pressure, the drug strategies seem logical. Either help it drain better or make less of it.
That's the core balancing act, yeah. Two main goals.
Let's start with increasing drainage. Miotics, the cholinergic drugs like pilocarpine, what do?
Cholinergics mimic the parasympathetic system. They cause meiosis pupil constriction.
Making the pupil smaller? How does that help drainage?
It's a mechanical effect. The drug contracts the ciliary muscle, which is attached near the drainage angle. This contraction pulls on the trabecular meshwork, physically opening up the drainage channels wider.
Ah, so it stretches open the drain, basically.
Much. Improves outflow through the canal of Schlemm.
Interesting detail in the text about eye color affecting this.
Yeah, it's fascinating. In people with dark irises, brown eyes, the pigment in the iris can actually absorb some of the pilocarpine molecule.
So less drug gets to the target muscle.
Right, meaning the miotic effect, and thus the pressure-lowering effect, might be less pronounced compared to someone with blue or green eyes. Might need a higher concentration sometimes.
Huh. Okay, next category, sympathomimetics. These cause mydriasis, pupil dilation, right, like dipifrin. How does dilating the pupil lower pressure? Seems counterintuitive.
It does seem that way, but they work on adrenergic receptors. It's a dual mechanism.
Okay.
Alpha receptor stimulation seems to enhance outflow, possibly through that secondary drainage route, the uveoscleral pathway. And beta receptor stimulation actually reduces the production of aqueous humor by the ciliary body.
So hitting both sides, increasing outflow and decreasing inflow.
Correct, though the balance varies between specific drugs in this class.
This leads us nicely to the beta blockers, like timolol, often a first-line choice.
Yeah, ophthalmic beta blockers are workhorses. Their main job is to decrease aqueous humor production. They slow down the faucet, basically.
Seems straightforward. Any catches?
Well, the big one is selectivity. Timolol is non-selective. It blocks both beta-1 receptors, which are mostly in the heart, and beta-2 receptors, found heavily in the lungs.
Even from an eye drop, does enough get absorbed systemically?
Oh, yes. Some systemic absorption via the tear ducts into the nasal mucosa, and then the bloodstream is unavoidable.
So if a patient has asthma or COPD,
using non-selective timolol could potentially trigger bronchospasm because of that beta-2 blockade in their airways.
or worsen bradycardia in someone with heart issues due to beta-1 block.
Exactly. It's a real risk, even with tiny drop doses.
So what's the alternative if someone has lung disease?
You'd want a selective beta blocker like betaxolol. It primarily targets beta-1 receptors.
Safer for the lungs.
Much safer. Less risk of respiratory side effects. So that choice between selective and non-selective is a key clinical decision based on the patient's overall health.
Makes sense. Now quickly, what about those osmotic diuretics like IV mannitol? When are they used?
Those are for acute glaucoma crises, or maybe right before or after eye surgery, not for chronic management.
How do they work so fast?
They make the blood hypertonic, super concentrated. This creates an osmotic gradient. Water gets literally pulled out of the eye, the aqueous and vitreous humor, back into the bloodstream by osmosis.
Drastically reducing the fluid volume inside the eye.
Right. Brings down that dangerously high pressure very quickly. It's a temporary emergency measure.
Okay. And finally, the one you teased earlier, prostaglandin agonists. Latanoprost is a big one, once daily dosing.
Yep, very convenient. These are highly effective. They work primarily by increasing aqueous humor outflow through that alternate route, the uveoscleral pathway. Basically opens up a distant drainage pipe.
And the side effect, the color change.
That's the unique and crucial one. Latanoproust and others in its class can cause a permanent increase in the brown pigment in the iris.
So if you have blue or green or hazel eyes?
Over months or years, they can slowly, permanently turn brown. It stimulates the melanocytes.
Wow. You absolutely have to tell patients that up front.
Non-negotiable counseling point. The change is irreversible, even if they stop the drug later. But for many, saving their vision outweighs the color change. Hashtag tag tag 2.3 ocular antimicrobials and anti-inflammatories.
All right, moving away from glaucoma to infections and inflammation, eye infections like conjunctivitis, pink eye are super common.
And highly contagious, especially bacterial or viral conjunctivitis. We also see keratitis, inflammation of the cornea or uveitis, deeper inflammation inside the eye. Table 57.5 in the text lists common pathogens.
So we use topical antibiotics like gentamicin and aminoglycoside or ciprofloxacin, a quinolone.
Yes, those are common broad-spectrum choices. There are antifungal drops like natamycin too, if needed.
And systemic side effects are pretty rare with these topical eye antibiotics.
Generally, yes. The doses are small, local application. The main risk, like with any antibiotic, is promoting resistance or allowing overgrowth of non-susceptible organisms like fungi. Always assess for improvement.
Okay, what about inflammation, maybe after surgery or an injury? We use corticosteroids like dexamethasone or NSAIDs like ketorolac or flurbiprofen.
Right, both reduce inflammation, but they work differently and have different risk profiles.
How do they work?
Steroids are broad. They inhibit phospholipase A2, which is way up high in the inflammatory cascade. Very potent anti-inflammatory and immunosuppressive effects.
NSAIDs.
NSAIDs target cyclooxygenase, COX enzymes, which are further down the pathway. Still reduce inflammation and pain, but less broadly immunosuppressive than steroids.
So steroids are stronger, but maybe riskier.
That's often the thinking, yeah.
Yeah.
For routine post-op inflammation or minor trauma, NSAIDs like ketorolac are frequently preferred initially.
Why prefer the NSAID if the steroid is more potent?
Because prolonged use of topical steroids comes with significant risks. Increased susceptibility to secondary infection, especially fungal, cataract formation, and ironically, they can actually increase intraocular pressure.
Worse than glaucoma, potentially.
Exactly. So there's a hesitation to use them long-term unless absolutely necessary for severe inflammation.
But wait, the text specifically mentions that ophthalmic NSAIDs like ketorolac can delay wound healing or cause corneal issues themselves. Isn't that also a big risk, especially after surgery?
It absolutely is. That's the clinical balancing act. Ketorolac can delay corneal epithelial healing and in rare cases contribute to corneal melting or perforation, particularly if used for extended periods or in patients with compromised corneas.
So it's a trade-off. Risk of steroid side effects versus risk of NSAID effects on healing.
Precisely. You weigh the severity of the inflammation against the patient's specific risks. Often, for uncomplicated post-op inflammation, the perceived risk of steroid-induced infection or IOP spike is considered greater than the risk of delayed healing from short-term NSAID use. But it requires careful monitoring. If healing seems slow, you might need to switch or adjust therapy. Use the lowest effective dose for the shortest possible time. Hashtag 2.4 ophthalmic diagnostics and safety.
We also use drops just for diagnosis, right? Like atropine or a cyclopentalate for eye exams.
Yeah, those are cycloplegic mydriatics. Mydriatic means they dilate the pupil, lets the doctor see the back of the eye better.
And cycloplegic.
That means they paralyze the ciliary muscle, the focusing muscle. This prevents accommodation, the eye's natural adjustment for near vision.
Why paralyzed focusing?
It allows for an accurate measurement of the eye's refractive error, basically, getting the right glasses prescription without the patient unconsciously interfering by focusing. Also helps visualize the retina clearly.
Okay. And what about fluorescein dye?
Fluorescein is cool. It's a yellow dye. When you shine a cobalt blue light on the eye after putting the dye in,
Yeah.
any breaks in the corneal surface, scratches, abrasions, ulcers, even spots where a foreign body was, will soak up the dye and glow bright green. Makes them really easy to see.
Handy. Now, for procedures like removing a foreign body, you need anesthetic drops like tetracaine or proparacaine. Fast onset, right?
Very fast, usually within 30 seconds. They numb the surface by stabilizing nerve membranes, blotting pain signals. Short duration too.
But there's a big safety warning here, isn't there, about patients using them at home?
Huge warning. These topical anesthetics are strictly for short-term professional use. Never prescribe them for patients to take home and use repeatedly for pain relief.
Why not? Seems like it would help with comfort.
Because the numbness masks injury. If the eye surface is numb, the patient can rub it or get debris in it and cause significant further damage without feeling it.
Bleeding, too.
Delayed healing, chronic non-healing defects, corneal scarring, infections, even corneal perforation and permanent vision loss. It's incredibly dangerous if misused.
And if the anesthetic numbs the blink reflex?
Then the eye loses its natural protection. It can dry out, get scratched easily. That's why patching the eye after using an anesthetic might be necessary until the sensation returns to physically protect it.
Okay, final destination, the ear. We've got the external ear, the canal.
Right, leading to the tympanic membrane, the eardrum, then the middle ear space behind it with those tiny bones, malleus and Gorse's stapes.
Two common problems here. Otitis externa.
Swimmer's ear. Infection or inflammation of that outer ear canal, usually bacterial or fungal, often related to moisture.
And otitis media, OM, middle ear infection.
Extremely common, especially in kids. Often follows a cold or upper respiratory infection.
How does a cold lead to an ear infection?
The eustachian tube, which connects the middle ear to the back of the throat, gets blocked by swelling and mucus. Fluid builds up behind the eardrum, can't drain.
And becomes a breeding ground for bacteria or viruses.
Exactly. Pressure builds, causes pain, sometimes the eardrum bulges or even ruptures.
And treatment for OM has changed a bit, hasn't it? Concerns about antibiotic resistance.
Big time. We've moved away from just automatically giving antibiotics, especially for mild cases or if it seems likely viral. Watchful waiting is often recommended now.
But if it's clearly bacterial and severe,
then the first line choice is usually oral amoxicillin. Simple, effective for the common culprits.
and if that doesn't work, or if they've had antibiotics recently,
Then you might escalate to something like amoxicillin clavulanate, Augmentin. The clavulanate helps overcome some types of bacterial resistance mechanisms.
makes sense. What about just treating the pain, which can be awful for kids?
Super important. Analgesics like acetaminophen or ibuprofen are key. And sometimes anesthetic eardrops containing benzocaine, like Oralgan, can provide topical pain relief while you're figuring out if antibiotics are truly needed. Hashtag 3.2, anti-infective and anti-inflammatory Otic drugs.
For infections mainly in the outer ear canal, otitis externa, the drops are often combination products.
Yeah, very commonly you'll see an antibacterial agent, it may be an antifungal too, mixed with a corticosteroid.
Like hydrocortisone or dexamethasone in the mix. Why the steroid?
It tackles the inflammation, the swelling, the itching, maybe any allergic component. Helps with symptoms and comfort significantly, alongside treating the infection itself.
Okay. Now, there's a massive safety alert here concerning certain antibiotic eardrops and the eardrum.
Absolutely critical point.
Yeah.
Older combination drops containing neomycin, polymyxin B, and hydrocortisone, these were very common.
Yeah.
They're absolutely contraindicated if the eardrum is perforated, or even if you just suspect it might be.
Why? What's the danger if the eardrum has a hole?
Because that hole gives the drug direct access to the middle ear and potentially the inner ear structures. Neomycin in particular is known to be ototoxic.
Meaning toxic to the ear, hearing loss.
Yes. It can damage the delicate hair cells in the cochlea, leading to permanent hearing loss or balance problems. Huge risk if it gets past a perforated drum.
So if there's any chance the eardrum isn't intact, you cannot use those drops.
Correct. You need to visually confirm the drum is intact first. If you can't, or if you know it's ruptured, you must use drops that are considered non-ototoxic.
Which ones are safer?
Fluoroquinolone drops, like ciprofloxacin or Ofloxacin, are generally considered safe to use even with a perforation. They don't carry that same risk of inner ear damage. Big difference in safety profile. Hashtag 3.3 earwax management.
All right, let's talk earwax or ceramin. Not an infection, but can definitely cause problems if it gets impacted.
Yeah, it's a natural protective substance, but sometimes it builds up too much, gets hard, blocks the canal, can cause pain, itching, temporary hearing loss.
So how do we deal with impacted ceramin? We use drops like carbamide peroxide, Debrox is a common brand. What do they do?
They're emulsifiers. Carbamide peroxide works by releasing hydrogen peroxide when it contacts moisture in the ear.
Creates oxygen, like it foams.
Exactly. It effervesces. That foaming action plus the glycerin, often included as a lubricant, helps soften and break down the hardened wax plug.
Making it easier to remove.
Yep. After using the drops for a few days, the fluff and wax can often be flushed out gently with warm water irrigation, maybe using a bulb syringe. Low pressure is key.
Okay. But safety first. When should someone not use these wax softening drops?
Similar caution as with the potentially ototoxic antibiotics. If there's ear drainage, significant pain, dizziness, or any suspicion of a perforated eardrum, don't use them without a doctor checking first.
Why? Risk of getting the solution into the middle ear.
Right. You don't want to introduce the chemical or irrigation fluid into the middle ear space if the drum isn't intact. Could cause irritation or infection. Hashtag 3.4 critical Otic administration technique.
This seems basic, but getting the administration technique right for eardrops is crucial for effectiveness and safety. Let's start with temperature.
Yes, this is fundamental. Otic solutions, eardrops, must be at room temperature or ideally body temperature before you put them in the ear.
What happens if they're cold, like straight from the fridge?
If cold liquid hits the tympanic membrane, it can cause a sudden temperature change that stimulates the balance organs in the inner ear, the vestibular system.
Dating too.
A really unpleasant reaction. Sudden, severe dizziness, vertigo, sometimes nausea and vomiting. Very startling and uncomfortable for the patient.
So warm the bottle first.
Just hold it in your hand for a few minutes or let it sit out of the fridge for maybe an hour. Never microwave it, obviously. Just gentle warming.
Okay. What about actually getting the drops in? You have to straighten the ear canal.
Yes, the ear canal has curves. To make sure the drops go down towards the eardrum and don't just pool in the outer part, you need to straighten it.
How you do that depends on age, right?
It does. For adults and kids older than 3 years, you gently pull the outer ear, the pinna, up and back.
Up and back for adults.
Right. But for infants and children under 3, their ear canal is structured a bit differently. It's straighter. So for them, you pull the pinna down and back.
Down and back for little kids. Got it. Any other steps after putting the drops in?
Yeah, 2 things. First, have the patient lie on their side with the affected ear up for about 5 minutes. Lets gravity help the drops penetrate.
Okay, 5 minutes.
Second, while they're lying there, you can gently massage the tragus.
The little flap of cartilage in front of the ear canal opening?
That's the one. Gently pressing or massaging it helps kind of pump the drops deeper into the canal and encourages distribution.
Okay, we've gone through skin, eyes, ears, lots of different drugs, different techniques. But the thread tying it all together is the nursing process, right?
Mm-hmm.
Assessment, planning, implementation, evaluation.
Absolutely. That systematic approach is what ensures safety and effectiveness, no matter which outer envelope you're dealing with. Let's talk about some assessment points that cross over between these systems.
Like allergies, we mentioned sulfa.
Perfect example. Assessing for a sulfa allergy is critical before using silver sulfadiazine on a burn. But you also need to remember that connection if the patient is prescribed certain eye drops.
Which ones?
The carbonic anhydrase inhibitors, or CAIs, used for glaucoma, drugs like dorzolamide or acetazolamide, they are chemically related to sulfonamides.
So a sulfa allergy is a potential caution or contraindication even for those eye drops.
It is. The risk of a cross-reaction is probably lower with topical drops than systemic sulfa drugs, but it's still there. You absolutely need to assess for that history.
Good connection. What else in assessment crosses over? We talked a lot about systemic absorption.
Right. Always assess the integrity of the barrier. Is the skin intact? Is it thin, like in infants or the elderly? Is it inflamed or broken?
Because more permeable skin means higher risk of the topical drug getting into the bloodstream.
Exactly. That topical steroid might cause systemic effects. That minoxidil might cause tachycardia, especially in vulnerable populations with thinner skin. Assessment guides your monitoring.
Okay, let's connect to implementation. We talked about eardrop technique. What about eye drops? The dosing dance?
Yeah. First, always hand hygiene, standard precautions. Clean hands, maybe gloves.
Where do the drops go? Not directly on the eyeball, right?
Never on the cornea. That stings and can cause injury. You gently pull down the lower eyelid to create a little pouch, the conjunctival sac. Aim the drop into that pouch.
Okay, drop in the pouch. Then what? This next step is crucial for preventing systemic effects.
It is. Immediately after instilling the drop, you apply gentle pressure with your finger to the inner corner of the eye, right over the tear duct, the lacrimal punctum.
For how long?
For 1 full minute.
Why? What does pressing there do?
It blocks the tear duct temporarily, prevents the drop solution from draining down into the nasal cavity.
Where it can be rapidly absorbed into the bloodstream through the nasal mucosa.
Exactly. This simple step significantly reduces the systemic absorption of drugs like beta blockers or cholinergics, minimizing potential side effects like slowed heart rate or breathing problems.
Critical technique. What if the patient needs 2 different kinds of eye drops?
You absolutely have to wait between them, at least 5 minutes.
Why the wait?
To give the first drop time to absorb properly and not just get immediately washed out by the second drop, ensures each medication has a chance to work.
Okay. And one more huge implementation safety point, confusing eardrops and eye drops. Otic versus ophthalmic.
Yes. The ISMP, the Institute for Safe Medication Practices, flags this constantly. The names look similar, the bottles often look identical.
So rule number 1.
Read, thigh, label. every single time. Don't rely on bottle shape or cap color because those aren't standardized. Double check if it says ophthalmic for eye use or otic for ear use.
What happens if you mix them up?
Putting eardrops in the eye is generally worse. They often have different pH or ingredients that can cause significant pain, chemical burns, irritation. Putting eye drops in the ear is usually less harmful, but it won't be effective for an ear problem. Always check the label.
Okay, last piece of the puzzle. Patient education. Empowering them to use these drugs safely at home.
Absolutely vital. Some general points apply to almost everything. Don't suddenly stop therapy without talking to the prescriber. Report any signs of worsening infection, increased irritation, or systemic symptoms like fever right away.
And the big one we keep coming back to, pregnancy risks.
Yes. Reinforce the rules for those Category X drugs, isotretinoin and tazarotene. The IPL-AD requirements, the absolute need for reliable contraception, the dangers. It cannot be overstated.
And you mentioned another one, finasteride, used for hair loss in men.
Right. Finasteride, Propecia, Proscar, is also teratogenic. Women of childbearing potential should not even handle crushed or broken tablets because the drug can be absorbed through the skin.
Risk to a male fetus if absorbed.
Correct. Important safety point that might get missed if you're just focusing on the male patient taking it.
Okay. What about those unique side effects we discussed? Patients need warning.
Definitely. You have to prepare someone starting latanoprost that their eye color might permanently change to brown. Manage expectations, avoid surprise or panic.
And for someone using ophthalmic and NSAIDs like ketorolac after surgery.
Educate them on the signs of delayed wound healing, persistent redness, discharge, changes in vision, increased pain. Tell them to report those symptoms promptly, as it might indicate a complication with corneal healing. These specific warnings build trust and ensure timely intervention. #outro.
Wow. Okay, that was indeed a deep dive. We've journeyed across the skin with its acid mantle and complex layers.
Navigated the different topical formulations, ointments, creams, gels.
Jump to the eye, managing intraocular pressure, understanding drainage versus production.
Highlighting critical techniques like intercanthus pressure and the risks of drugs like latanoprost or misused anesthetics.
And finally landed in the ear, discussing otitis, the dangers of certain drops with perforation, and that crucial temperature rule for administration.
It's a lot, but the core message, I think, that ties this whole unit together is this. Pharmacology for these outer envelopes is uniquely tied to the how.
How the drug is formulated, how it's applied.
Exactly, and how vigilant you are. Vigilant about local irritation, potential systemic absorption, allergy crossovers like sulfa.
And underpinning it all, that consistent nursing process. Assessment, planning, careful implementation, evaluation.
That's the key. Mastering that process is what ensures safe, effective patient outcomes when you're dealing with the complex pharmacology of the skin, the eyes, and the ears.
An excellent summary. That knowledge hopefully feels more connected and actionable now.
We hope so.
Thank you so much for digging into this material with us today. We really appreciate you tuning in. We'll catch you on the next deep dive.